Good afternoon. Today is my talk on the unraveling the diagnostic armamentarium of glaucoma. So there is no financial interest. So nowadays in glaucoma we have too many choices. In all these technique we are sometimes confused what to do. So let us take one by one. There is a lot of dynamism in diagnostic armamentarium starting from IOP measurements to CCT measurement, anti-chamber angle measurement, optic nerve assessment. So one by one we will take, and first IOP measurement. Goldman applanation is the still gold standard, but lot of new technologies like eye care rebound tonometer is better tolerated than Goldman. No anesthesia is required, and nowadays lot of refractive surgeries are going on. So we need a corneal thickness independent tonometry like this dynamic contour tonometry, and DCT data we are flat across the spectrum of corneal thickness reading, unlike the Goldman applanation. So this DCT is least affected by refractive surgeries. Next one is the ocular response analyzer. It is based on corneal hysteresis and can be used a risk factor for development and progression for glaucoma. And this ORA gives data about the GAT correlated IOP, corneal compensated IOP, and corneal resistance factor. So next comes the anti-chamber angle assessment, gonioscopy, and lots of other imaging techniques. So first take gonioscopy, indirect one is the most common. It will give us about the angle measurement, grading, about iris configuration and roots, any deposits, synechies, pigments, new vessels, or if any nodules is there. So gonioscopy is the most critical instrument. We have to give 2-minute time in our busy OPD procedure, OPD time. We are doing OCT and a lot of imaging, but we are not taking time of 2 minutes for this Goldman. So it will give us idea about it is open angle or close angle. Next comes the various imaging technique in anterior segment. This is ASOCT and UBM. So anterior segment OCT has a lot of application. It will give high resolution and screening for angle closure. It will give blab imaging and position of tube in shunt surgery. It will do pachymetry, and we can assess the effect of PI or tube, and also useful in malignant glaucoma and plateau iris detection. OCT has a non-contact and no indentation method, shorter imaging time, and is highly reproducible and easily documented, but it is limited only to anterior to iris. It is unable to penetrate iris and ciliary body zonule not clear. So there comes ultrasound biomicroscopy. It images all angle component posterior to iris also. It images iris ciliary body complex, and it is also possible to study the behavior of iris and angle under various conditions. As compared to ASOCT, it is a high resolution. So UBM is very crucial to detect the functional status of filtering surgery, malignant glaucoma, and pigment dispersion syndrome. You can easily watch the typical posterior bowing of peripheral iris. Next one is a pentacam is the only good screening tool for antechamber volume and dynamics, and limitation is difficult angle assessment as no direct angle visualization. Next comes is optic nerve assessment. We can do with a slit lamp with the help of 90D or 78 diopter, and it will give a good stereoscopic view and can detect early RNFL defect. You can take photography also by stereoscopic methods. It used to document structural abnormalities, and it is highly reproducible and record a natural color or image of the retina. Next is the quantitative imaging. We have OCT, HRT, and GDX. All three has a different principles. So have a look on this all three. You can see that optical coherence tomography is has a strong assessment of RNFL and ONH It is a very versatile instrument, and very highly specific. 90% specificity is there in a OCT, but less reliable on poor signals. Otherwise, GDX and HRT are observer dependent and image quality are lowest in the GDX. So we prefer usually in the OCT. Apart from OCT, RNFL should not be we interested in a macula GCC scan, ganglion cell complex scan, because 50% of retinal ganglion cell are found in the macular region. These are the normal macular scan. Therefore, measurement of this GCC is more effective than evaluating RNFL alone in diagnosing early glaucoma. Next comes the OCT angiography. OCTA is a routine test of future. So if we combine OCTA plus OCT RNFL, it will be a powerful diagnostic tool. Peripapillary optic disc and macular OCTA parameters show a stronger functional association with visual field. Very accurate in advanced myopia, advanced glaucoma, myopia, and atypical optic nerve head. But it lacks normative database, motion artifact, and observer dependent. Lot of future imaging techniques are developing in this scenario. Last but not least, the visual field assessment, that is the functional assessment, is a very must. So 24-2 and 32- is a method of choice, but many times this 24-2 misses defects which will be detectable on 10-2. And 10-2 is a good choice when relating GCC functional damage to structural changes, especially early glaucoma, OHT, and suspects. Virtual perimetry is also coming and very promising, but it unable to defect that match standard automated perimetry and unable to demonstrate ability in early to moderate glaucoma. So lastly,
Dr. Dilip, can you just wind up quickly?
Last
Yeah.
This is we have, if mixed clinical equipment plus testing, that it will give a good results. So we have forgotten clinical skill, which works very well when our OCT machine does not work. So diagnostic testing are complement to good clinical skill, not a substitute. And interpretation should be taken cautiously after the correlation with the structure and function. And serial OCT scans are useful in diagnosing early glaucoma that may fall under periperimetric glaucoma.